Welcome to the AUA News Inside Track podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
Hey everyone, I'm Dr. Matt Nielsen, Chair of AUA's Science and Quality Council and Chair of the Department of Urology at UNC Chapel Hill. We at AUA have been really excited about a lot of opportunities in our specialty to take part in a national movement to embrace the concept of diagnostic excellence. The National Academy of Medicine had a report on diagnostic error in 2015 that was part of their Crossing the Quality Chasm series, laying out for us the many opportunities we have to improve the diagnostic process. And as a specialty in surgery without a corresponding medical specialty, we do a lot of diagnosis working with our primary care colleagues and colleagues from other specialties. And so we are really, really excited about opportunities in this space. Today, I'm thrilled to welcome my great friend, Andre Periscu from Cleveland Clinic. Dr. Periscu is a abdominal radiologist with a lot of interest in GU imaging, a lot of experience, and has been a national leader who we've worked with at AUA over the years. He was a key participant in our 2017 QI Summit on imaging stewardship and has been a great friend and colleague since then. Follow-up conversations from that with Andre helped us at AUA learn more about some of the incredible work that our colleagues at the American College of Radiology have been doing. And that led to an opportunity for us to get together and have another QI summit focused specifically on the topic of MR imaging and fusion biopsy as key elements of the diagnostic pathway for prostate cancer patients in 2025 and beyond. And so I'm just so grateful to Dr. Periscu for his friendship and the many contributions he and his colleagues have made. And we are excited to have this conversation today to share with our AUA members a little bit more information about this. Andre, could you just tell us a little bit more about yourself?
Well, first of all, Dr. Nielsen, thank you so much for the kind words and for the invitation to participate in this podcast with you. It's been a tremendous honor for me to take part in all the initiatives that you have been leading the way through the American Urological Association. Being in the summit there, I've learned a lot from other colleagues. And again, this has been a very productive partnership. So I appreciate the opportunity. As you mentioned, I'm an abdominal radiologist. I currently serve as a section head of abdominal imaging here at the Cleveland Clinic. And I also serve as a physician leader for the American College of Radiology Prostate MR Image Quality Improvement Collaborative. And so it is my pleasure to be here speaking about some of these initiatives with you today.
Excellent. Thank you, Andre. So as most of our members know, but we may have some listeners from outside the specialty or others who are newer to this topic, we've had a real transformation in the detection and early diagnosis of prostate cancer in the last 10 or 15 years with the advent of useful pelvic imaging with MRI as a way to help us know better where to go after prostate biopsy. And when used prior to biopsy, prostate MRI has showed increased or maintained detection of clinically significant cancers, decreased overdiagnosis and overtreatment of insignificant cancers, a fairly substantial reduction in potentially avoidable biopsies, and ultimately lower healthcare costs. These changes have been really helpful as we have had ongoing conversations with our colleagues in primary care about revisiting the opportunities for early diagnosis of prostate cancer. The use of MRI has really helped address a lot of the concerns that traditionally pushed against the use of PSA testing in terms of overdiagnosis and overtreatment, and ultimately for our patients to be able to get the appropriate diagnosis as quickly as possible. This has been a transformational innovation. We also acknowledge that with any new technology, there is the potential for some variation in the consistency and proficiency of execution. And we refer to the published series from major centers as we're thinking about our practice and counseling our patients. But we've learned in every topic area, not just this one, that as new innovations disseminate, that there are opportunities to get everyone to that highest level of performance. So I was just so excited to learn from Andre earlier in the last year or two about the great work that he and colleagues at ACR have been doing, and would love to just invite a little bit more conversation about that, Andre.
Yeah, and that's exactly right. I think the key word is variation, and we saw prostate MR starting to be starting using in clinical practice around the 2000s, and then that increase slowly ramp up. But really, the major concern for implementation in practice is the variation in quality, and so in many ways, and how the exam is performed and how the exam is reported. And for that reason, for that very reason, the prostate image quality reporting data system, or PIRADS, was established. It was first established in 2012. The colleagues from the European Society of Uroradiology, they started with a consensus paper in what's now called the PIRADS version 1. In 2014, they joined forces with the American College of Radiology through support from the AdMetech Foundation, and that really helped create the PIRADS version 2, which again includes not only the technical considerations for performing prostate MRI, but also this now very popular 5-point scale that we use to characterize lesions on MR. It's a 1 through 5 scale, where 1, that the probability of clinically skin cancer is highly unlikely, all the way to 5 when the probability of clinically skin cancer is highly likely. And so really, once that framework was established, it has really helped popularize the use of MRI in clinical practice. And I have to say that, that paper, the PIRADS version 2, was published not in a radiology journal, but it was published in a European urology. And that really caught the attention of our friends in urology, and they demanded that radiologists start using this. And so we need to credit the work from the urologists in partnership with their radiologists that really helped disseminate the use of the PIRADS scoring system. So fast forward 2019, that has a new version of the system, which we call PIRADS version 2.1. And despite being, present for over 10 years now, there's still variability. We still encounter variability despite the existence of the technical standards defined by the PIRADS system. And so, in order to try to address some of the assessment of the quality of MR, in 2018, when the Precision trial was a major trial, a multi-center trial looking at the comparing MRI to standard biopsies. And that trial that was published in the New England Journal of Medicine, it's one of the landmark trials showing the benefits of MR. They created this tool for assessing image quality. And so that was the prostate image quality system, or PQAL, which also has been revised. And last year, we published the second version of the system in collaboration with, the colleagues from the European Society of Radiology. Dr. Francesco Giganti is one of the leaders of that work. And now the PIQAL, which is now reporting the 3-point scale. And the PIQAL 1 means that the scan is inadequate. It should be repeated. PIQAL 2, that means the acceptable scan. It should be repeated when necessary. And PIRADS 3 means PIQAL 3 means the scan is optimal and has the highest diagnostic quality. So we're always striving to get the PIQAL 3 in our scans to make sure that we have the full benefit of the MRI in place. And so this is the kind of background of the story behind PIRADS and PIQAL, which are these two systems now that exist. And we're trying to push more and more for our friends in radiology, not only to include the PIRADS system or PIRADS scores in the reports, but also to include the quality assessment. I think that that's key, as we recognize that the issues with quality of prostate MRI are prevalent.
Excellent. Well, thank you so much for sharing that. And I thought it was really fascinating when we were, talking about this, in lead up to the meeting. I think, many of us just sort of observed over time that, PIRADS kind of gradually trickled in, and it made such a huge difference, once that became consistent, to be able to, communicate to our patients and, make better decisions and have that consistency with, all the complex information that's in those multi-parametric MRIs communicated in a clear way. I think, to your point, the partnership and sort of mutual appreciation of urologists and radiologists was really key to that, and feels like is a great roadmap for us to take it to the next level and really understand more about what we are learning about opportunities to improve the consistency of image quality. I think for many of us who take care of patients across a wide geographic area, we've had some anecdotal experience with variation in image quality, and sometimes a center that may have, you know, older technology or a different protocol or, whatever other factors may not give us the images that we might come to take for granted. We never take you for granted, Andre, but we come to sort of get used to in our local community practice. So help us know more about the work that you and your colleagues in ACR have been leading in terms of helping to make that consistent and proficient execution of the scans more the standard.
Yeah, so there are two major initiatives. One of them is the ACR through the ACR Learning Network, so the Prostate MR Image Quality Improvement Collaborative. So the Learning Network was created by the ACR to help disseminate quality work throughout different areas in the specialty, and prostate MR image quality was just one of them. And through this work, we've worked with about 13 organizations across different places in the United States just to try to identify what are the key issues that lead to poor image quality and what are the most effective ways of solving the problem with image quality. Essentially, the program focuses on the four key pillars that we've uncovered throughout this program, which is patient preparation, which is really one of the essential parts of the exams. There's definitely variability in how patients are receiving preparation, but we know that doing preparation is better than not doing any preparation at all. And this here is one of the key things that I think that the urologist can help us, which is explaining to patients why it is important to do the preparation before they have the prostate MRI done. We also work on consistent protocol management and making sure that physicians are using PIRADS compliant protocols for prostate MRI. We identify personnel training as one of the key limitations. Technologies, unfortunately, they come out of training sometimes with doing less than 5 prostate MRIs, and we know the prostate MRI is a pretty complex examination, and it's hard to achieve high quality consistently. And so that's why we need to focus on improving the personnel training, not just for the techs, but also for the radiologists to recognize the issues with image quality and how to troubleshoot problems as they see them. And lastly, the process for auditing the images. Again, this is the part where, including the PyQual scores, the report can really facilitate the image centers to audit the quality of their MAR scans. And so when we work through these four pillars of image quality, again, preparation, protocol, personnel, and process for auditing the images, we've seen a tremendous improvement overall in prostate image quality in the centers. Through this work that we did, about a third of the exams did not have sufficient image quality, and through the work with ACR, we have helped the centers achieve the 85% benchmark of, 85% of the exams have optimal image quality. So this is one of the efforts that we have done. The second one that it's worth highlighting is the prostate cancer MRI center designation. So the designation is different than accreditation. The accreditation is something that is required by CMS for outpatient billing. Insurances, they also require centers to have MRI accreditation. So the ACR created a step further, and this is also optional, but essentially this designation is created to highlight the centers that go above and beyond. These are centers that not only follow the PIRADS standards, but they also have demonstrated expertise in prostate imaging. And that includes, having physicians with expertise, with a minimum number of cases performed, technologies with expertise. And equally important is that these sites should have a red path mechanism to correlate the biopsy results with the MRI. And so this is an essential piece for us to try to, benchmark the center in terms of, how well they perform the biopsies, how well their MRI exam is being read. And this is also a safety net for patients in cases when there's a discrepancy, the biopsy and the MRI results. This can really help determine what's the next best step for the patient. So these are the two main initiatives that I think are worth highlighting in terms of, quality. Obviously, the ACR offers also a number of other education opportunities for physicians who wanted to become, um, gain expertise in prostate MRI. They're both online training and also in-person training at the Ed Center in Virginia, for example. We have a training course where physicians, on average, go over about 130 prostate MRI exams, all with red path correlation. So this really helps physicians who are not in high volume centers to gain the expertise and the confidence that they need to accurately read the prostate MRI exams.
That's terrific. Yeah, I think such amazing work, and congratulations to you and the team for the tremendous results that you've seen in those first several cohorts. I think one of the things from our summit meeting that was really impressive to me is that A, the centers that were participating in these first several cohorts were the recognizable places that, were already, I think, we would all just sort of believe and assume to be, excellent quality. Across the board, there were opportunities to improve, and that I think is a great lesson for all of us. Where I think until we start, really challenging ourselves and asking the question, we don't know. Better knows no limit. So we don't know, how good it could be. The other thing that I thought was, really interesting from the presentations you all shared was just how very reproducible the improvements were with those multiple facets. That were addressed in the process. The different cohorts, the rates of improvement were almost overlapping. It was really impressive to see how consistent that was, and I think that speaks to the scalability and the opportunity that we now have as a community of physicians across radiology and urology who care a lot about this topic and these patients to really make the commitment to go there. I think given the uh, administrative responsibilities I have here at UNC, I appreciate, and I know you do also, given your role at Cleveland Clinic, Andre, that any sort of new projects like these often require some investment of time and commitment from staff. And so I think as a practical matter for those of us responsible for making budgets and things of that nature, another really key takeaway from those cohorts that I think is important for people to appreciate is that in addition to improving the image quality, which is, good enough in and of itself, that those process improvements led to decreased scan times, increased throughput with the same scanner footprint and staff. And so the opportunity to, get patient access and get patients moved through the system more quickly was one very key takeaway point that I'm bringing back to our leaders here to help support that work. Also, uh, really impressive to me and sort of inspiring were some pictures of the teams celebrating their accomplishments. And I think we all recognize in healthcare our jobs are hard. A lot of our teammates have lots of opportunities to work lots of places, and we're sort of fighting over a limited pool of talent. And so I think centers that invest in this kind of work, it's professional development for the teams. They take pride in their work. I would argue that it's probably a great recruitment and retention tool for those critical staff members. So congratulations, and we're excited again to share this with our broader community.
Thank you. Yeah, and it's true. And just to share with the audience in terms of what that represented, at least for one of the institutions who actually took the time to look at how much savings that would represent, that was over 300 hours of magnet that was freed because of the standardization of the process. For another organization, that was equivalent to almost $500,000 in terms of available scan time that would translate into additional exams they could accommodate. So you're absolutely correct. I think in terms of access, there's a huge benefits for the organizations and downstream for patients as well. So and people come for the prostate MR, but they stay for the quality improvement. And I think that was the goal that the ACR has. Prostate MR image quality is just one of the several projects that can be tackled through this program. But certainly for prostate MR is there's some big gains beyond just simple improvement in image quality. And I think offering a better product, more consistently, I think everybody wins.
Excellent. Well, this has been such a great conversation, and we're excited at AUA to package this material together in a variety of different formats, this podcast being one, but we're also putting together a proceedings paper and a quality improvement implementation toolkit that will be available on the AUA website so members and other interested parties can find out where these different resources exist. We are at AUA very committed to this concept of diagnostic excellence. We're really grateful for the support of the Gordon and Betty Moore Foundation and the National Academy of Medicine for supporting this particular effort. We're also grateful for the Council of Medical Specialty Societies under the leadership of Helen Burston, really bringing this topic to the forefront and supporting the work of all of our different specialty societies to work together to improve diagnosis for our patients. we will continue to work with ACR, with Andre and his colleagues, to improve prostate MR image quality. That leads to improved biopsy quality. And as another element of the meeting and another resource that we're putting together through AUA, working with colleagues at the Michigan Urologic Surgery Improvement Collaborative, and other institutions that have done some important quality improvement work on the next phase of the process, taking that MRI, ideally very high quality, top shelf MRI, informed by the kind of quality improvement work that Dr. Prisco and his colleagues have laid out for us, then applying that to fusion biopsy and understanding, where our opportunities for performance improvement lay there in the urology office. So we plan to develop a quality improvement issue brief on this topic that will be a document forthcoming. That will also include references and resources to the PIRADS and PIQUAL reporting, as well as the different quality improvement efforts that Dr. Prisco has summarized. So just want to thank our AUA staff, who are the unsung heroes of all this work. They are working behind the scenes to help us bring this terrific programming together. So thanks particularly to Karen Johnson, Emily Calvert, and Kiana Confessor, who really are our superb quality team. Thanks also to my colleagues Ray Tan and Zach Foyer here at UNC, who've done some important work on the space, and the other participants in the QI Summit. And most of all, thank you, Dr. Prisco, for your friendship and just incredible, inspiring leadership on all of the important things that are there for our patients.
Well, it's my great pleasure. And again, I can't tell you how much I appreciate being part of this work with AUA. As I talked to you before, urology is my second family, and I very much appreciate the opportunity to work with you, the AUA staff, and obviously my colleagues in the ACR as well. So thank you very much for the opportunity.
Excellent. Thanks, Andre. So thanks to our listeners for joining us on this podcast. I hope it was inspiring and provided some useful information for you. For additional information on prostate MR image quality and fusion biopsy, please visit auanet.org/QI Summit. This is Matt Nielsen from Chapel Hill, hoping that everyone is having a great day.
This has been an AUA News Inside Track podcast. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.